So we know that there are 3 approved vaccines in the United States. We have the Moderna vaccine, the Pfizer vaccine, and the Johnson & Johnson vaccine. We know that COVID-19 has impacted the country at large in a very significant manner. These are unprecedented times that we are in, going on 18 months. We also know that African Americans and Latino Americans, Black and brown people, have been seen to be more susceptible to getting infected, to getting hospitalized, and having more deaths. Now that's an important and unfortunate thing that we have to reconcile with. And the question is why? Some people think it's genetic, but the truth is that it is not genetic at all. What really predisposes African American people to the disease, COVID-19, is because we tend to have more of a preponderance of risk factors that might make us susceptible to disease in general, such as high blood pressure, diabetes, smoking, living in crowded situations, having to do types of work that expose one to the public. Now, let me emphasize that we all know the African American population is not one population. It is not a monolithic population. But it is true, and the evidence is unequivocal, that there have been disproportionate deaths, hospitalizations, and infections in African Americans. So if we look at the population in North Carolina, there are 22% African Americans of the total population in North Carolina and 70% Caucasians, and the remainder are primarily Latino. I'll come back to that in a second. We've heard about the variants that are now ravaging the United States. We know that there has been a significant adoption of vaccinations to some degree between the months of January to July. But in June, July, and August, there have been significant uptakes in the number of cases with COVID-19. More than 90% of these cases are in people who are not vaccinated. 22% of African Americans make up the population of North Carolina. And if we look at the population of African Americans that have actually been vaccinated, what we find is a much lower number of African Americans being vaccinated compared to Caucasian Americans. We have about 25% of total vaccinated people that are African American. That's a very low number. And that's fully vaccinated. It's slightly higher for African Americans that have gotten a single shot. So what we find here is a disturbing observation that while the susceptibility for severe disease from COVID-19, need for hospitalization because of advanced disease with COVID-19, and a risk for increased death among African Americans, we have a very low vaccination adoption. Now, there are reasons for this. And in fact, African Americans are not alone in populations that are not maximally vaccinated. There are generally 4 categories of people that have not been vaccinated adequately as of now. And race is one category that it's been observed, such as in the African American and Latino community, that not enough of our people are getting vaccinated. But it's not the only one. People in a lower socioeconomic class, irrespective of race, also for obvious reasons, logistics reasons, education reasons, are not adequately vaccinated as well. Children mostly don't have authority over decision making. They depend on their parents. The vaccine is approved only in a certain age group of people in the child and adolescent group. And the fourth group is those that have very strong political, partisan reasons not to want to be vaccinated. But I want to focus on the African American community. And in broad strokes, I want to dispel a lot of the confusion and help elevate us above the noise and the controversies around the vaccines. Now, as a physician, I'm very well informed about the history of medical experimentation in Black and brown people in the United States that goes back centuries. There is a painful legacy of abuse of Black and brown people by the health industry in the United States. This is nothing new, and it is by no means lost on me as I speak to you today. We know about the Tuskegee experiment that started in the mid-1930s through the mid-1960s. What is not generally known is that there are many Tuskegees that have been chronicled in the history of medicine in the United States. Several have been attempted to be expunged from the literature. But as a student myself of health disparities in the United States, I am deeply aware of this history, and I'm deeply aware of the impacts of this history. And therefore, I understand the skepticism and the suspicion that exists when confronted with sweeping decisions that are coming down from public health authorities. That's why I painstakingly went through the organizational bodies that adjudicate over development, decision-making, and distribution of new drugs such as vaccines. So, as of now, we have an opportunity to understand more about the trials. I've personally looked at these trials. Truth be told, I had not made any decisions about whether I would get the vaccine, whether I would recommend that my family and friends would get the vaccine until I had a better understanding of the data. And it is the data that we should focus on. I will say that the Moderna and the Pfizer clinical trials, which were these two vaccines are referred to messenger RNA vaccines, were done and adjudicated under the auspices of the NIH. Now, you may have heard that historically African Americans do not tend to participate in clinical trials for obvious reasons, because irrespective of race, some people feel that clinical trials are experimentation. Not surprising that with a history of experimentation, with adverse intent and effect on African Americans, it will be no surprise that there might be some skepticism here. And in fact, if we look at national clinical trials in the history of United States clinical trials development, the percentage of African Americans in trials has been abysmally low. And still yet, the information that's coming out of those trials has been applied to African Americans without representation in those trials. Now, let me say one thing about the Moderna and Pfizer and the Johnson & Johnson trials. In the early stages of those trials, Pfizer and Moderna in particular, the NIH realized through very meticulous tracking that there were not representative numbers of Black and brown people in those trials. They halted the trials with instructions to the trial clinical investigators to revisit their approach to enrolling candidates, because we had to be sure that the results of the trials were applicable to representative races within the United States. The black population in the United States is between 12 and 13%. I'll tell you that in the Moderna and the Pfizer trials, the black population enrolled in each of those trials was about 10%, lower than the 12% African American population percentage, but close to it. And I will tell you that that was an impressive jump compared to historical trends, which generally are in the 5% level, at the 5% level. Interestingly, the Johnson & Johnson trial enrolled 16% of African Americans in the total population in that trial. The point I'm making here is that the NIH observed lack of representation. Black and brown people told the trial design leaders to make sure they enrolled more. Why? To demonstrate that the science was applicable to all populations. So let's talk about the science. There is unequivocal evidence adjudicated by rigor and discipline that the vaccines work. And what do I mean by they work? They are likely to prevent infection, and if you get infection, they're likely to reduce the severity of the infection such that there will not need to be a hospitalization, and even less likely a mortality, a death. The two messenger RNA vaccines have higher efficacies demonstrated during the trial, and efficacy speaks to efficiency during the duration of the trial. They're about 95% for those two. And the Johnson & Johnson vaccine had lower efficacy during the duration of the trial at about 70 to 75%, but enough efficacy to reduce the chance of infection and to obviate the need for hospitalization and to almost certainly eliminate the risk for death. I mentioned the word efficacy a number of times because, again, that refers to efficiency during the trial. Now the vaccine is approved by the FDA. It's approved under the designation of emergency use approval. And that is another point of potential concern because people may think that this is still an experiment. But the truth is that the FDA has the empowerment to approve drugs that have compelling evidence scientifically of overwhelming benefits to be approved under emergency clauses in the case of a severe threat to humankind, as we're in now, in the setting of a global pandemic. The drug will not get emergency use approval except if there is compelling data, as there is, within the context of the clinical trials. But then again, the clinical trials lasted about 5 months, which is a fair amount of time. What's more important is to understand how do the drugs now perform in human population in general, which now addresses a larger population of people across the entire country and indeed across the world. And the behavior of drugs in the human population after the clinical trial, we talk about efficiency, efficacy during the trial, efficiency in real life experience. And we find thus far, 8-9 months after vaccines are now deployed for mass use, that the efficiency is almost as high as it was during the clinical trials in the 90s for Moderna and Pfizer, and in the low 70s for Johnson & Johnson, but we also find that they do the same things intended. That if you get vaccinated, your risk for infection is significantly reduced. The disease, if you get it, is likely to be mild, that won't necessitate hospitalization, and the risk for death is significantly reduced. So there's been some questions about the speed for development of these vaccines, that this has come down at, so to speak, warp speed, and therefore there must be something wrong. Again, there's the rooted suspicion that some continue to have, and that's understood. And there's the noise that says there's a conspiracy in the federal government with this vaccine. I'd like to dispel that. The messenger RNA technology is not really new. It actually has been in existence for about 20 years, just waiting to be deployed when a vaccine was needed. And I'll say that all vaccines in current iterations of vaccine therapy involve injecting some type of vaccine virus element into the human body. Whether it is an influenza vaccine or a measles vaccine or a smallpox vaccine, it does involve injecting a part of the offending virus into the human body so that the human body can elicit an antibody response that will recognize when the real infection is around and counteract it. So the messenger RNA is a new way of delivering, of manufacturing, of enabling the body to manufacture a protein that is similar to the COVID-19 spike protein. It's a synthetic, genetically driven, that enables your cells to make, and first of all, to make that spike protein, which is inactive and which is rapidly destroyed. But before it's destroyed, it makes antibodies so that if you get exposed, your body is primed to be resistant. Not just with antibodies, but there's a second line of defense called B cells and T cells. So the science is strong. The safety is validated. No drug is free of side effects. We must understand the difference between side effects and complications. There is a database that has been collected and is being populated from the beginning of the trials to identify side effects as well as complications. Side effects usually occur within the first week, and they're the usual side effects you could expect if you get the flu vaccine. There might be some soreness at the site of injection. There might be mild fever, chills, rigor, fatigue, loss of appetite for a couple of days within the first week. Those side effects are usually tolerable. There's a big question that people have about complications. And we've heard about complications, such as people developing blood clots, people developing enlarged hearts because of heart inflammation. We've heard about complications because people may develop problems with their nerves. All of these are true. The risk of complications occurs in less than 1% of the human population. Less than 1% of people thus far have been shown to have complications. So I'm quoting information for you that tells us we're tracking this, and the risk is not small. It is minuscule to have a complication. It doesn't mean that we should ignore complications. We should be aware of the potential. And if you have significant concerns about your personal situation, I suggest that you try to step above the fray and the noise. Don't believe everything you hear, and try to get credible information that suits your own particular health status. And that information is best obtained from a healthcare provider, not from lay people that are spreading conspiracy theories, but we can get factual information.